The general theme of these grand rounds are topics related to healthcare epidemiology, infection control, infection prevention, antimicrobial stewardship, and this is, of course, employee health. Then last grand round, we have a very interesting presentation related to the new OSHA regulations that is going to apply in healthcare. Today, keeping in the topic of infection control, hospital epidemiology, when we have an outbreak in the institution, we want to do an epidemiological investigation. A common design that we have for clinical studies or for investigations is the case control design. And then we asked Thomas Chandler, that is one of our biostatisticians here in the Norton Infectious Diseases Institute, to give us an overview from a statistical point of view, an overview of case control studies. And Thomas accepted this challenge with the understanding that he's primarily a statistician, but he's been working with us a lot in infection control. Then he's going to tackle case control studies where we are looking at hospital-acquired infection. Thomas?
All right, thank you for the introduction, Dr. Ramirez. So yes, today we'll be discussing case control studies and hospital-acquired infections. So just a quick overview of today's presentation. So I'll introduce case control studies and discuss when it's appropriate to use them, some of the advantages and limitations that are in these studies, and how to construct a 2x2 table from case control studies, and then the calculation of an odds ratio and how to interpret an odds ratio. And then I'll kind of bring it all together with an example that involves central line associated bloodstream infections in pediatric patients. So kind of to start off, I think it's good to introduce some basic concepts when it comes to case control studies. So these are going to be retrospective in design. So what that means is you're going to be starting at some specified time point and looking back over a certain period. So one of the first things you'll want to do is start by identifying cases and controls. And for studies, it's good to have a very specific definition of what a case and control is, but in its most basic definition, a case is going to be an individual who's developed a specific disease or has some outcome or event of interest. And alternatively, your control is going to be a healthy individual. I use healthy loosely because it could still have other factors, but these are going to be your people without the disease or event, or without the event of interest. And so then once you've identified your cases and controls, you'll want to look back and see which past exposures or risk factors that these groups have experienced. And you'll calculate what's called an odds ratio, and this will help you measure how strongly a disease is associated with a certain exposure. So we'll use these terms kind of throughout this presentation. So just wanted to introduce them early on. So when designing a case control study, we kind of already talked about these, but I think it's good to have a visual representation as well. So you'll start with your cases. You can see this guy's not feeling very well. He's got his mask on. So you start with defining your disease cases, then you find your control group. Hopefully they're a little bit happier because they don't have the disease, and then you'll look back over time and see if they were exposed or if they weren't exposed. So this is a very simple representation, but I think it's good to kind of lay the foundation of what these studies are trying to achieve. So when is it appropriate to use a case control design? So these studies are very useful when the disease or outcome of interest is very rare. So if we were to do a prospective cohort for a rare disease, some of the subjects in that cohort may never develop that disease. And alternatively, when the prevalence is extremely high, then you may overestimate the relationship between an exposure and a disease, because with high prevalence, there comes the high chance of exposure to a variety of factors. And then also, these are very useful for investigating outbreaks, because you can quickly identify your cases and then look back and see the commonalities between your disease cases and what exposures they share. And when the AIDS epidemic started in the 1980s, these type of case control study designs were very useful, because they were able to quickly identify, cases of this new disease that was emerging, and then look back and see, what these disease cases shared, what they had in common. So what are some advantages when it comes to a case control design? These are usually fairly quick and cheap to perform. If compared to a prospective cohort, those studies tend to cost more money and can be more time consuming if you're following a large cohort of patients. Also, the manpower behind performing those studies is also, there's more people needed to perform studies. And it's also easier to identify all cases of a disease than all individuals who are potentially exposed. If we think about COVID and the current pandemic, if we wanted to identify all exposed individuals, then that would most likely be everybody. So it wouldn't be very useful to identify everyone who has been exposed. There are a few limitations to highlight. So with case control studies, we can't really estimate incidence rates since we're not following a cohort and looking for the onset of disease. So we can't really say much about incidence with these studies. And there's also a few sources of bias that we may come across. So recall bias happens when the individuals in your study may not recall prior exposures accurately. So if you're assessing a vaccine and the prevention of a disease, if your patients or your subjects may not recall if they were vaccinated or not, that will cause problems later on if you're trying to determine, who was exposed and who was not exposed. Also, bias by indication can occur when certain diseases are not necessarily causally related with certain exposures, but high exposures are seen with certain diseases. Also, it can be difficult to identify a set of controls that is similar to your cases. So the idea with having the controls is having a set that has similar characteristics, with the exception of the fact that they don't have the disease. So it can be difficult to identify a decent set of control individuals. So with case control studies, constructing a 2x2 table is a very useful tool. So if you look at the bottom of this slide, we have our 2x2 table. It's kind of just the basic setup that hopefully we've all seen before. So if we look across our columns, we have our cases and controls. And if we move down the cases column, A plus C will be our total number of cases. And alternatively, B plus C will be our total number of controls. So just in cell A, if we kind of look back to our visual that we were introduced earlier, cell A is going to indicate our cases who were exposed. Cell B will indicate our controls who were exposed. Cell C will indicate our cases who weren't exposed. And cell D will indicate our controls who weren't exposed. And then our total number of N is just going to be the sum of all A through D. So once we've constructed our 2x2 table, the next step is to calculate our odds ratio. And if you think kind of like a court of law reference, the odds ratio is going to be the evidence that we need to kind of support the fact that a certain exposure is associated with a disease. So it's a ratio. So there's two pieces that you need when calculating an odds ratio. The first is going to be the odds of exposure in our cases. And this simply just reduces down to the number of cases with an exposure divided by the number of cases without an exposure. So if we're looking at our 2x2 table, it's going to be A divided by C. And then alternatively, you need the odds of the exposure and the controls, which reduces down to the same thing, which is the number of controls with the exposure divided by the number of controls without an exposure, which is going to be B divided by D. So once we have these two pieces, we can now calculate our odds ratio, which is just going to be the odds of exposure in the cases divided by the odds of exposure in our controls, which we just specified as A divided by C divided by B divided by D, which is usually represented as A times C divided by B times C. And without having to go through that process, I just kind of remember that if I draw an X, we multiply A by D, and then we divide it by B times C. So it's just a simpler way is just kind of making that X in the table to kind of calculate your odds ratio. So it's important to know how to calculate our odds ratio, but it's more important to understand how to interpret what this is actually telling us. So keep in mind, this is a ratio, so it's two numbers that go into this. So when our odds ratio is equal to 1, that means what's in our numerator is going to be similar to what's in our denominator. So the odds of disease won't differ by exposure status. If our odds ratio is greater than 1, that means what's in our numerator is higher than our denominator. So the odds of disease is higher among our exposed, and that exposure is a risk factor for disease. If our odds ratio is less than 1, that means our numerator or denominator is going to be larger and the odds of disease is lower among the exposed, and that exposure is protective against an outcome. And usually, well, hopefully each time you see an odds ratio, it will have a 95% confidence interval with it. And what that confidence interval is providing us with is a range of plausible values that we would see if we were to recalculate our odds ratio. And if that odds ratio in the 95% confidence interval contains 1, then we don't really have sufficient evidence to conclude that disease status will differ by exposure. So basically, if our point estimate may be greater than 1 or less than 1, but if that confidence interval contains 1, we don't really have enough evidence to conclude that the disease will differ by exposure status. I don't really touch on confidence intervals too much in this presentation, but I just kind of wanted to lay that foundation. So this brings us to our example. So this is going to be a study from 2018, which assessed risk factors for acquiring central line associated bloodstream infections in patients admitted to pediatric intensive care units. And I just want to highlight that this study is out of South America and won't represent hospital systems in North America, such as Norton Healthcare. So if anything that's presented here seems controversial, I apologize. But so the idea here is just to determine risk factors for these central line associated bloodstream infections. So looking at this study, it's important to understand the parameters that we'll be discussing. So our population is going to be 170 pediatric patients with a central line in place for at least 24 hours. And the exposure that our researchers are interested in is the number of central venous catheters categorized as one CVC or more than one CVC at once. So we have our sample, we have our exposure. So now we need to determine the number of cases of central line associated bloodstream infections. And so out of this 170, we had 31 cases, and then we have 139 controls. So we'll also need to determine which of our cases and controls had our exposure. So out of our 31 cases, we had 23 patients with more than one central venous catheter. And out of our controls, we had 41 patients with more than one central venous catheter. So with this information, we can construct our 2x2 table. So you can see in our cases, we have 31 total. In our controls, we have 139 total. And for our exposure, which is highlighted in orange right here, we have 64 total. And so we have our 2x2 table constructed. We can now calculate our odds ratio, which we know is A times D divided by B times C. So simply just have to plug in the numbers from our 2x2 table, and we get 6.87. So that's great. We have our odds ratio, but what is this actually telling us? That's the more important thing. So what this is saying is that the odds of a central line associated bloodstream infection is 6.87 times higher in patients with more than one central venous catheter. So potentially this may be a risk factor for these central line associated bloodstream infections, but we'll touch on more on that later. But so let's say the researchers also wanted to assess the use of antifungal drugs as a risk factor for these central line associated bloodstream infections. So we have the same cases and controls, but we're just swapping out the exposure that these patients had. So based off this study, we identified 21 of our cases that were exposed and 19 of our controls that were exposed. So we can basically reconstruct our 2x2 table. Once again, we're just changing out our exposure variable right here. And we can recalculate our odds ratio, which is 13.26, which is much higher than the odds ratio that we calculated before. What this is telling us is that the odds of these bloodstream infections is 13.26 times higher than the patients who receive an antifungal drug. So also wanted to present the results from the multivariate analysis on this study. So the researchers also identified 7 other risk factors for these bloodstream infections, and all these associations were univariately associated with the outcome. So it's always important to adjust for confounding with studies. Univariate associations are kind of a good first piece of evidence, but you always want to control for confounding variables. So all of these risk factors were included in a multivariate logistic regression, which controlled for confounding. And after controlling for these other variables, more than one CVC was associated with these bloodstream infections, and also the duration of CVC use was associated with these bloodstream infections. So if we look at our crude odds ratio, we can see that 6.87 is what we calculated from our 2x2 table. And also just wanted to highlight the adjusted odds ratio and how this estimate was affected by the confounding of these other variables. So now we have a lower estimate for our odds ratio, and there's also a smaller range of plausible values in our 95% confidence interval. So by adjusting for these other factors, we have a more precise estimate than what we originally would have thought just based off of our 2x2 table. So basically here, I just kind of wanted to highlight the importance of adjustment and how crude estimates will change when we adjust for other factors. And here's the reference for that study if anyone's interested in it. And I think that is all I have. So we can open the floor for questions or any questions.
Great, Thomas. Thank you very much. Very nice overview. I want to see if there are any comments or questions, but Thomas, I was a question. I want to start with a question. You've been discussing now odds ratios, and sometimes there's a confusion with odds ratios and relative risk. And sometimes the statisticians, telling us that we are not supposed to use these two words interchangeable, but sometimes there is a possibility that may means the same or not. Could you tell us in the cases that you presented, even though it's clear that you calculated the odds ratio, in our mind, it would be appropriate to think of these numbers as relative risk, or this would be inappropriate?
So when you're talking about an odds ratio and a relative risk, those two numbers, the thing that they have in common is they're explaining some relationship between a disease and exposure. But with a relative risk, you're assuming that you know everybody who has been exposed. Whereas odds ratios, you just know everyone who has the disease, and then you're looking back to see if they had a certain exposure. So if you were to interpret it, you could say that the risk for a certain disease is, changed by a certain exposure. But I guess the difference between those two quantities is the fact that one, everyone who has been exposed, and the other one is just going to, everyone who has the disease.
Kind of on that same topic, is there a tendency when comparing relative risk ratios and odds ratios, given that an odds ratio is formed with less information, is there a tendency to either underestimate or overestimate risk as compared to the relative risk? So
I know when the disease prevalence is fairly low, odds ratios approximate a relative risk. So with a relative risk, it's kind of, from a numbers perspective, it's more ideal because you have more information because you know everyone who has been exposed. But as the disease prevalence starts to change, you're introducing more exposures. So I think the best answer there is just the fact that how the odds ratio will approximate the relative risk when the disease is less prevalent.
Thanks.
This is the statistical answer in all the textbooks. Less prevalent disease or ratio, we can think of relative risk. The problem is that sometimes I don't know from a clinical perspective, what is a low prevalence disease? But I imagine that my guess is always that when we are looking here in the hospital setting, as you alluded here, you have an outbreak of bloodstream infection related to a catheter, you have an outbreak of multi-resistant Pseudomonas, ventilator-associated pneumonia. These are usually diseases that we may have 5, 6, 10. You have 20, you have a catastrophe. You have 40, I mean, you need to fire your infection control because you went several months without recognizing that you have a problem. Then probably most of these cases, Thomas, will you say that all these will be low prevalence diseases when we are dealing with healthcare-associated infections? Of course, assuming that you have an appropriate infection control team that is recognizing these problems early on.
So yeah, ideally it would be a low prevalence situation. I think from an infection control perspective, I think the biggest thing is just identifying those cases early on, and then identifying your cases, and then looking back for certain exposures or risk factors or reasons why you're seeing this outbreak. But in terms of specifying what would low prevalence be, it's kind of hard to kind of make a hard and fast decision on.
So I like the example, and it seems that in infection control, just the constructing of a 2x2 table is sometimes, if you haven't done this before, then it can be a little bit frightening. Especially one of the common problems that I'll hear is that when you mention exposure, then people automatically think of exposure to whatever organism has been identified as problematic, instead of, an exposure to the in this case, the catheter itself. What is the device, or what is the situation that may be involved as having that causal relationship. And so you might have some suggestions on how to practice with constructing a 2x2 table. So you begin to feel comfortable with the concept, because then once you start building those, then it takes you away from some of the knee-jerk response that I think I know what the problem is already. And then we don't do, as you had mentioned earlier, that that this becomes really your evidence that either your hypothesis about, about relationships or causality, may have some validity, and it takes you away from thinking that you already know the answer and not having a methodology. So if somebody wants to practice with 2x2 tables, do you have a suggestion?
Well, I think it's always useful to just kind of look back in the literature and see, what examples are available, and then trying to reproduce the results that they found in those studies, kind of what I did with this example today. So I think there are a lot of good resources online that just kind of have very straightforward examples, but I think the ones that are available actually in literature and being able to reproduce those is a good way to practice. So in terms of like resources that I use, I kind of, if I ever want to like learn more about certain subjects or concepts, I usually just will turn to YouTube. So I think that it's always good to watch videos and have visual representations as well.
Then essentially what what you're saying is that from a statistical point of view, exposure is a statistical terminology. Probably we in clinical practice, when we're looking at these cases, we may be looking more like a risk factor.
Mm-hmm.
I always say that cancer-related bloodstream infection, risk factor, yes, no. And then, of course, the risk factor is coming from the line listing and all these things that we do. It's a different topic. But we look at, and again, essentially risk factor, you've been exposed to this risk factor.
I think, that's a good point, because sometimes we'll say, well, let's use a case control study to look at an MRSA outbreak. And sometimes that can be really difficult if you're trying to deconstruct the problem before you start constructing a table. That, instead it's like, what can you actually get your arms around with that outbreak, and then begin to look at, what again are the risk factors. And I think Stephen had put in the chat that, starting with something simple like looking at gender or age may help you begin to think about, well, what does age have to do with this? What are the differences between the cases, the people that have the infection, and the controls, the approach that you're going to use in trying to understand what difference gender makes, if it does, or what difference does age make. So just beginning to practice with that, so you can figure out which cell to put those pieces of information in, and then how you do that, cross multiplication, and then come out with the answer, and then how to articulate the answer, just as you describe. Well, what is that number 6.37? What does that mean? And then as you're beginning to convey that message. So it's something that takes a little time, I think, so to play with in practice.
Mm-hmm. And if you kind of wanted to get an idea of what could potentially be a risk factor, you can always look kind of what characteristics are prevalent in your cases and controls, and then looking to see if that is a risk factor. So kind of like in that table 1 breakdown, if there's a high proportion of males in your cases, then you could look at gender, like you said. So I think looking at kind of like what the data is saying is a good way to start, but then also having that biological rationale to kind of justify, is this just kind of an association by random, or is there actually, some clinical relevance to it?
So do those risk factors or those exposures make sense with what you're doing? So
yes.
Do we have any other comments? Since we, in the example that you give, Thomas, I think I was having more than one central line. Before adjustment, you have almost an odds ratio of 7. And then after adjustment, this decreased to half or less than half. then will you consider that to define really an odds ratio, the crude odds ratio is something that we can use clinically, or we should always do an adjusted odds ratio?
I think you're always going to want to use your adjusted estimates, just because your crude estimates, you're just looking at one exposure and one outcome. And realistically, in reality, there's an infinite amount of confounding variables that could potentially, affect your results. So you want to adjust for things that may be associated with your exposure and also your outcome. So the adjusted odds ratio is going to be your best estimate.
Are there any good available resources to do logistic regressions? So it looked like the 2x2 table seems simple enough, but to get the adjusted odds ratio, that's
right. Yeah. So I didn't really want to touch.
The core of my question, but see, can we do it? Because the 2x2 table odds ratio is very simple to do.
Right.
Without consulting a statistician. But now Thomas said, no, you need to do multivariate logistic regression. He wants to maintain his job. He said, you cannot do anything without me. Do the 2x2 table because this is not enough. Then now Matt wants to know, Thomas, what can I do to learn the multivariate logistic regression? They don't need to call you.
Well, Matt, how good are you with R programming would be my first question. But really, so it comes down to getting those adjusted estimates. We rely heavily on our statistical program just because the pen and paper derivation of these adjusted estimates is pretty taxing. Mm-hmm. And I'm sure you have a headache after watching this presentation. So if you tried to go calculate some adjusted odds ratios, you'll probably have an even worse headache after that. So I would definitely, softwares are going to be your best bet. If you wanted to kind of mess around with some softwares, I would look online for like available data sets and understanding the structure, and then trying to produce some random logistic regression model in R maybe, or whatever software you want to take a stab at.
Yeah, no, I'm probably not going to do any of this. So but I'm always curious to see if there's any free software I could use.
Well, R is free.
Oh, is it? Okay.
Yeah.
Is R what you use, or do you use SAS or SPSS or?
So we usually just stick to R. It's kind of what I've used mostly for years. I've been exposed to SAS and SPSS a little bit, but it's not kind of my preferred programming language.
And as Thomas mentioned, you go 15, 20 years ago, probably Thomas wasn't even born. Then we were SAS, SPSS, but then these statistical programs became so expensive. But to me, when R appears, I don't know how old is R. I don't know if anyone knows when R came to, because R is almost, remember the story of Red Cap, no? When Red Cap was specifically developed for clinical research, and it's open access, and it's like a type of Wikipedia. Everybody contribute to Red Cap, and R is the same concept. It's open access. It's open. Everybody contribute. Then there was no question that in our group in infectious diseases, we just went to R. Doesn't mean that I understand R, but I said we went to R, and everybody that joins the group keep getting better at R, and being open access. Then you need to collaborate with other universities or with other countries. You know that this is going to be what people are going to be using more and more. Then I may say, Matt, if you want to get some hands on R, I think that Stephen and Thomas will be our local experts, and they can give you some lessons in the evening.
Yes.
After hours.
Yeah, no, definitely.
I was going to make a comment that if we wanted to stick to the simplicity of a 2x2 table, and you had a main exposure of interest, you could do a matched case control design. So you could match the cases and controls based on a couple other potentially confounding variables, and that could end up giving you at least a simpler odds ratio that way.
Yeah, this is a very good point, Thomas. This is something that is an issue when we are trying to do a case control study, is that the cases are very simple because we have a definition, but the controls is, I mean, how much of the control you want to be similar to the cases and how much separated from the cases, and then you have the concept that sometimes you guys are saying that you are overmatching or over controlling or not enough. Then if you want to have separate, very separated, you need to do probably the logistic regression. But if they are very close, you may just do it with a 2x2 table. This is Stephen what you are referring.
Yeah. So in a matched design, typically you would want to, like, let's say we want to match on age range and gender. So then for every, female older adult patient that's a case, we would look for a female older adult control. And then we limit the controls that we have in the model based on the cases then, because usually the controls that you have are going to be from the same time frame, and you'll probably have, depending on the rarity of the disease or the event, you'll probably have far more controls than cases. And
that's when I was talking about the bias by indication, it's difficult to indicate a good control because like Dr. Ramirez said, you don't want it to mirror your case group too much because then you won't see any granularity with your outcomes. So you don't want to overmatch per se. So there's difficulties that arise when specifying a good control.
So when you're using this process kind of in real world, in a infection control setting, then kind of the take-home points are, looking at your cases and trying to understand the meaningful or risk factors that make sense, and begin to, and I know Dr. Ramirez, you mentioned about, we're not talking about developing a line listing today, but starting off with that type of information and then seeking out someone that can help answer questions about how you begin to organize this information so that you can begin this type of analysis. And at the end of the day, that's the reminder that when we have these situations, it's very dangerous to assume that you already know the answer to why these things happened, and that it is important in order to fix whatever problem may have impacted this outcome, that you need to have a method for gathering that information. So beginning to practice and looking at situations that maybe are very simple. Maybe you just have a few cases of some event, that start using that as a way to practice, and then having someone that you can call that may be able to help kind of check my work. Was I thinking this through correctly? So that you become more comfortable with the process and then are able to use it when you have a real situation where, correct or accuracy in your interventions may mean the difference between ongoing exposure, ongoing transmission, or resolution.
Any other comments or questions from the group? But Thomas, I think that it was an excellent review. This already suggested in this discussion, we already have several other statistical topics that we may want to discuss. As always, we are going to, we try to come out with almost, we have like a 30-day cycle in our mind. That's going to be every 30 days, we're going to have some form of statistical review, and then in 30 days some form of more infection control, antimicrobial stewardship, hospital epidemiology, and then we keep rotating. And then just to understand that this coming week, Ruth, what is the topic this coming week?
Well, last week we talked about the OSHA standard and the application in acute care settings. And next Wednesday, we'll talk about what CMS is doing with this. So this not only reinforces what we need to have in acute care, but also the importance in other healthcare settings beyond acute care. So just, you know, how is the federal government applying these expected controls as we look at the future of COVID and safe care?
I think we're going to go back to another topic related to the federal government regulation, in this case in long-term care.
Yes.
And then we are going to be, we have in mind, be looking at the pathophysiology of some of our nosocomial infection. We started with a pathophysiology of central, the catheter-related bloodstream infections, and also there was an interest in doing a ground rounds on evaluating sentinel events. Then these are the topics that are going to be coming in the next weeks. With this, Thomas, again, thank you very much for this great overview, and thank you all of you for your attendance. I will see you this coming Wednesday. If there's any topic that you think that is of relevance, just let us know, because we can change the schedule immediately if there is an area that is relevant for our everyday practice. Thank you.
Thank you.